Good evening, everyone. Thank you for the invite. And before beginning the talk, when it comes to surgical treatment of mucinous cystic neoplasms, the surgical decision making and execution there is nothing much unique to MCN. It is more or less because decided on the location of the lesion and to rule out malignancy is the biggest concern, or a suspicion of malignancy is the biggest concern. So the background, it's a distinct cystic tumor of the pancreas, produces mucin epithelium, and a subepithelial ovarian stroma is a hallmark, which at times it's very important to differentiate from a branch duct IPMN when the imaging is not so classical. It constitutes around 10-15% of pancreatic cystic neoplasms, usually predominantly in female, usually in the 5th decade, and vast majority occurs in body and tail of the pancreas. The risk of invasive carcinoma is there, 16%, may be reported up to 36%. One interesting thing is, even though men are less likely to develop mucinous cystic neoplasm, those who develop mucinous cystic neoplasm are at least 3 times higher risk of developing invasive cancer when compared to females. Embryologically, the dorsal pancreatic bud and the genital bud lie adjacent to each other during embryogenesis, and this could possibly explain migration of ovarian rest inside the pancreatic bud. And since dorsal pancreas gives rise to body and tail of the pancreas, this can possibly explain the common location of MCN as well. Physiologically, it can be a benign, having low-grade dysplasia, high-grade dysplasia, or an invasive cancer. They are usually detected incidentally. If symptomatic, usually the abdominal pain is very vague. Early satiety may be present at times. Obstructive jaundice may suggest malignancy when it is clinically present. Imaging is usually CCT and an MRI. It's a cystic lesion, peripheral axial calcification will be present. The following features like asymmetric chest wall thickening, mural nodule, solid component within the cyst, rapid increase in size, vascular or adjacent oral infiltration may suggest malignancy before surgery. And EUS and FNA is very important to characterize the cyst better, to rule out malignancy, and also it helps in analysis of the cyst fluid. So coming to the biomarkers, the mucin is positive because it is secreted. CEA in the cyst fluid of more than 192 nanogram per ml confirms a mucinous cyst, but it cannot differentiate benign and malignancy. Usually they have low amylase because it is unusual for an MCN to have ductal communication. DNA analysis of the cyst fluid also can be done. A KRAS mutation is present in both MCN and IPMN. GNAS mutation is specific for IPMN. SMAD4 and T53 mutations suggest carcinoma. Serum markers are really not helpful. CA is not useful. CA99 is not specific. However, when it is in higher levels, may suggest malignancy. Is there a role to operate all patients, or there is a role of surveillance? So original International Association of Pancreatology recommendations was to surgically resect all MCN irrespective of size, because it usually occurs in young patient and the disease had unclear natural history and there is a definite risk of malignancy. With the more knowledge of cases, the newer guidelines still have a scope of surveillance in asymptomatic cyst which is less than 4 centimeters with no high risk features. This avoids a surgery and in turn avoids a short-term morbidity and the long-term pancreatic insufficiency. The caveat here is there is no definite endpoint for surveillance in these patients. Otherwise also it is resource consuming, not generalizable. So coming to the surgical procedures, distal pancreatectomy is the most commonly done procedure. Whipple is done when the cyst is located in the head of the pancreas. It can be open or minimally invasive. The most common morbidities are in the short-term post-operative pancreatic fistula, which is more in distal pancreatectomy, but it is self-limited. Pancreatic hemorrhage, delayed gastric emptying. In the long term, up to 55% of exocrine insufficiency is reported and 30% new onset diabetes mellitus is reported. And these two, there is no difference between a distal pancreatectomy and a Whipple's pancreatic duodenectomy. Coming to the technical aspects, when we have to do a distal pancreatectomy and we have to divide the pancreas and manage the pancreatic stump, how to divide and how to manage the stump. So division can be done with a knife or a cautery. The duct can be ligated if it is seen, and fish mouthing closure of the pancreatic stump can be done. Or it can be divided with a stapler, or a hybrid approach where this divided with the stapler and reinforce the staple lines with sutures also can be done. If it is cut without the stapler, the stump can be left just with closure, or a bowel serosal patch can be used. With all these things, there is no relationship between the type of closure technique and the fistula. It mainly depends on the pancreatic texture and the thickness. In this image, if you can see in the left side, the first image, the choice of stapler is wrong, where the stapler is thicker than the pancreatic stump. So the occlusion is incomplete, giving rise to leakage. The second thing, the pancreas is thicker than the stapler. So there is pancreatic capsule damage and pancreatic fracture that happens just proximal to the staple line, again giving rise to fistula. And when we use reinforcing sutures after a staple, even the needle holes can give rise to pancreatic juice leakage. And thicker pancreas with a thicker staple line, there is always a chance of delayed opening up of the staple and giving rise to fistula. So the important factors before deciding on use of stapler and selection of stapler includes the pancreatic texture, pancreatic thickness, and the closed limb of the staple limb. So unlike the Whipple's pancreatic duodenectomy, where softer pancreas are difficult to handle, in distal pancreatectomy, softer pancreas are easy to compress using staple and have favorable outcomes, whereas a hard pancreas is difficult to close with a stapler and they have a high risk of pancreatic fistula. So pancreas thicker than 17 mm or maybe up to 2 centimeters, it's better not to consider stapler and prefer hand-shown closure, and this can be assessed preoperatively in the cross-sectional imaging. And whenever we are using stapler, it's better to use the prolonged graded peripheral compression where the stapler is not closed and fired at a single moment. We give enough time for the compression and firing so that the compression and firing is adequate to prevent a postoperative fistula. Apart from these, in adjuncts like patching it up with omentum, falciform ligament or bubble serosal patch, usage of glue and reinforced staplers are all available, but there is no single magic bullet to avoid a postoperative pancreatic fistula following a distal pancreatectomy. Should we remove spleen in all patients? Why it should not be removed? Because it has a long-term infectious complications and thrombotic complications. If it is a clearly benign lesion, the spleen can be preserved. The Kimura technique where the splenic vessels are preserved or the Warsha technique where the splenic vessels are sacrificed can be used. So the first one is this Kimura technique where the entire course of splenic artery and splenic vein is dissected and preserved. Only the tributaries or branches to the pancreas is taken out. It is technically difficult. There can be chances of bleeding which may require the procedure being converted to a splenic Warsha technique or a splenectomy. The second is the splenic vessel sacrificing procedure, Warsha's technique. In this, we should particularly preserve the short gastric vessels and the left gastric epiploic vessel to avoid splenic vascular compromise. Again, this can have an incidence of splenic infarction and abscess in up to 5 to 10% of the patient. And long-term gastric varices incidence has been reported up to 30%, even though most are clinically silent. So when it is not advisable, when there is a suspicious malignancy, splenic vessel involvement, suspicious nodes, or at the end of a splenic preservation, if the spleen vascularity is not okay, it's better not to preserve the spleen. Role of lymphadenectomy, non-invasive MCN is having risk of lymph node metastasis only less than 2%, whereas invasive MCN has up to incidence of 20%. So when there is a clear-cut benign lesion, preoperative assessment wise, there is no role for regional lymphadenectomy, whereas when it is suspicious or a proven invasive malignancy, the standard lymphadenectomy should be followed. The lymphadenectomy has been extensively discussed in the morning session. When it comes to drain versus no drain, there is no difference in incidence of fistula whether we put or do not put a drain, but the severity of the pancreatic fistula is high when the drains are not placed. So the trials have shown that higher mortality in no drain groups, and they have also failed to prove non-inferiority of non-placement of drains. So routine drain placement will be a better middle path, and we can consider removing the drain early in appropriate low risk cases. Coming to parenchyma sparing pancreatectomy, why should we do this? Because this disease is a low malignant potential disease, often benign when diagnosed, and we should take into consideration the long-term exocrine and endocrine insufficiency after a major surgery like Whipple's or distal pancreatectomy. The options include enucleation, central pancreatectomy, or a DPPHR. When it comes to enucleation, it is just shelling out of the lesion from the pancreatic parenchyma, preferably done when the lesion is less than 2 centimeters. It preserves most of the parenchyma, but the fistula rates are pretty high, goes up to 50%. We can use sharp dissection and suturing of bleeding points, or we can use energy sources like bipolar, ultrasonic shears, or QSAR to shell out the lesion. Before doing this, two things has to be very clear. The lesion should be definitely benign. The lesion should be less than 2 centimeters, and the relationship of the lesion with the pancreatic has to be assessed properly. If the distance is less than 3 millimeters, it's better not to do enucleation for the risk of duct injury. So intraoperative ultrasound will help us for this particular reason. So once the lesion is out, what should we do for the cavity? The cavity can be left open, or it can be closed if it is possible, and it can be plugged with an omentum, or when there is an associated ductal injury, if it is possible, we can do a cavitogenostomy as well. And what to do with the ductal injury? The ductal injury we can observe intraoperatively when there is continuous watery usage into the cavity, or under magnification at times we can see the ductal injury as well, or with the use of fine probes we can probe the duct and confirm the ductal injury. When it is a minor injury, adequate drains, a cavitogenostomy itself is okay, and sometimes we can try and repair the duct also, but it is a tedious process, may not be helping us. Major ductal injury like transection, it is better to convert that into a standard procedure, be it Whipple's or a distal pancreatectomy. Coming to central pancreatectomy, this is done for lesions which are confined to neck or proximal body of the pancreas. Although it is very difficult to clearly delineate neck and proximal body, what we should see is how much remnant pancreas is left towards the body and tail. If the remnant is adequate, we can do this procedure. It is contraindicated when malignancy is suspected. It preserves the parenchyma. The problem here is we will be dealing with two pancreas stems. The proximal stem or the right stem can be suture closed or stapled. The left side stem needs entry anastomosis. It can be done either with a pancreatic jejunostomy or a gastrostomy. It is not simple as a distal pancreatectomy. It's a technically challenging procedure. Fistula rates are higher. However, the long-term endocrine insufficiency and exocrine insufficiency are far less when compared to a distal pancreatectomy or a Whipple's procedure. Duodenal preserving pancreatic head resection is technically possible in expert hands when the lesion is confined to head, benign, and is not amenable for an enucleation. However, it needs technical expertise, should be done in high volume centers only. Minimally invasive surgery for a distal pancreatectomy, yes, it has benefits in terms of less blood loss, transfusion-less hospital stay, higher spleen preservation rates. It's oncologically safe. There is no difference in fistula rates. When it comes to Whipple's procedure, even though the short-term benefits like less blood loss, transfusion, less hospital stay may be there, the outcomes are not just dependent on the incision, so it should be restricted to experts in high-volume centers. Adjuncts for surgery, intraoperative ultrasound can be used to identify the duct, and sometimes we can reconfirm the cystic characteristics if it required. Coming to frozen section for a mucinous cystic neoplasm, it is not always required because it is more or less a clearly well-defined lesion. If after transection of the pancreas, if the adjacent pancreas looks suspicious, maybe it can be used to ascertain the margin. If it is operated for a malignancy, on a case-to-case basis, you can use. And when we are seeing suspected nodes intraoperatively, the nodes also can be sent for frozen section. ICG, pancreatic stump perfusion, has been discussed some time back, so it may not be useful. As of now, we don't know how to interpret that also, so clinical judgment is better than relying on ICG alone. If at all we end up doing a DPPHR and we want to pursue the CBD, ICG will be helpful to visualize the CBD during the procedure. To conclude, option of surveillance is still there, but it has to be judiciously selected on a case-to-case basis, taking into disease factors and other logistics also into consideration. Rather than asking the patient to be on surveillance, patient get lost to follow up and come back with the malignancy later. Distal pancreatectomy is most commonly required. Whipple's for head lesions. Spleen preservation is often possible. Carefully selected patients with expertise can be subjected to parenchyma sparing approaches. Minimally invasive surgery is safe in distal pancreatectomy. Whipple's, I think it should be restricted to experts in high volume centers. Thank you.
Sir, I have got one question. Sir, in your practice, when based on imaging, if you are very sure that it's not a serous malignancy, serous neoplasm, how does endoscopic ultrasound assessment help you to change the management?
Endoscopic ultrasound primarily they use to establish the mucinous neoplasm one. The second, if at all we have a suspicion of a malignancy like an asymmetric thickness in the wall or a mural nodule, we use that. Otherwise, to establish a diagnosis of MCN may not be required always. It's a problem solving tool, it should not be a routine investigation for an MCN.
Spleen preserving distal pancreatectomy, are you having any specific indications for it in case of background of MCN? Because invasiveness cannot be determined by this preoperative. Then you, after resection, sometimes there is invasive malignancy will be there, it will affect the prognosis.
Yes, sir, that's what, if we have any suspicion of, even a smaller suspicion of malignancy, it's better not to preserve the spleen for two reasons, one for invasion, other for lymphadenectomy purposes. If you are very sure it is a benign lesion, on a case-to-case basis, you can do spleen preservation.